Hello, my name is Jason Heron. I am presenting the ethical considerations in end of life counseling. I like to present a rationale because I think it's always important to kind of understand how we got here. And why I chose this is because death is very complex. And when we talk about end of life counseling, that is a complex topic. And so I wanted to find something that was complex enough to be able to kind of really dig my teeth into it, and also it was kind of interesting. Um, you know, I think it was either week one or two. There was a scenario within the text, and individual had a terminally they were terminally ill, and um, the scenario basically presented like what would be our response. And so I thought that the right thing would, be to, okay, I'm going to continue to provide counseling to this individual and support them, because within the scenario they said they plan on ending their own life. And so I thought that that was the right thing, looking at the concept, because right before that we were talking about the concept of autonomy, and within the notes of that scenario, it actually said that I was wrong in my approach. And so that really made me think like, wow, this is a lot more complex. And when I saw the scenario, I was thinking like, this seems like it should be a slam dunk, but I know it's not. It's required me to do a lot more thinking. But I never even considered, contacting a lawyer and things like that. So it really got me interested about this topic. Death is an important part of our human experience. Is one of the things um, that that we all have to deal with, but we don't like to talk about it. And I think it's important that we are equipped and able to talk about these type of things with our clients, because it's a very uncomfortable topic, but a very crucial one. And so that is the reason why I chose this topic. So the interesting thing about our modern world is, because we have advanced so much with our medicine and our technology, it really have changed our expectations surrounding death. If you think about it, just 100 years ago, the human lifespan was so much shorter. The things that people died of 100 years ago, we shrug off like it's nothing today. I don't know how many people in this class are old enough to remember, there was a game called Oregon Trail back when computers first started to make their ways into K through 12 classrooms. And on this game, um, there's a joke that um, what you're trying to do is you're trying to make your way through the Oregon Trail, and you can catch a dysentery and die. And it's kind of a funny thing now to think about it, but 100 years ago, 200 years ago, um, the slight ailments that we get now would kill people. And so one of the things that has come because of that is humans live a lot longer. But because humans live a lot longer, we also are, people have the ability to have new diseases which cause them to have more suffering. And so now that people are living well beyond the years of the past, people can now have these prolonged incidents of higher chronic diseases, um, which leaves individuals in extreme pain sometimes. Um, a lot of people who died earlier may not have ever been able to have the chance of getting like cancers and things like that, 100 years ago. But now we have people who are living well into their 90s and hundreds, and it can be very painful if you get certain types of illnesses. So counselors may have to have clients who are in extreme pain with low likelihood of survival from whatever they're going through. These individuals may want to discuss their options for end of life care. So it's important to be kind of educated on how these things work. A counselor's ethical duties remain intact in these scenarios. So just because somebody is at an end life situation, you still have all of the ethical considerations, and your client may require even more because they may be going through a lot of different feelings. So let's talk about some of the important terms. There's a lot of things that I did not know before I started doing this research, and it was really good to address these things because I've learned quite a bit. Um, so, active voluntary euthanasia is the act of terminating a life at the request of the patient. Um, One of the things that I learned when I started to do this research was I thought that I was going to talk about all end of life situations, whether it was suicide or through euthanasia. But what I realized is that they are treated very differently within the literature. And so I ended up not going into the suicide um, at all. And this presentation is really about these two terms: active voluntary euthanasia and physician-assisted suicide. So that is what active voluntary euthanasia is. Passive euthanasia is the act of withholding life-saving interventions. This is something that's completely different. Active voluntary euthanasia is something that is highly restricted within the United States. Passive euthanasia is completely different because instead of actively terminating an individual's life, what you are doing here is withholding um, interventions and allowing them to die naturally. Suicide is the act of self-termination. We're not going to talk about that, but there is a distinction. I want to identify what that key term is because it is very much different, and I'll contrast suicide with all of these other um, terms in a second. Physician-assisted suicide is the act of termination which requires the help of another individual. Generally, when we talk about physician-assisted suicide, we're talking about an actual physician or under the care of a physician, but the physician or the nurse provides the patients with the means of termination. A lot of the times it is some type of pill or some other type of um, intervention that they give to the patient which allows them to self-terminate. Um, this is rare. This is more common than the euthanasia. Euthanasia is highly restricted within the country, and persistent assisted suicide is also restricted. And then there are cases of assisted suicide, which is it is not done by the physician. This gets into murkier waters because, like there was a case that I was reading where a son gave his mother mashed up like morphine pills, and she took all of them and died. And it was her wish, so it was assisted suicide, but it got him into some legal troubles because it is not that is a complex scenario, and it is not always legal for that. In most places, it is not legal within the United States. So, thinking about this topic, I had to determine how am I going to address this. So during my research for the presentation, it was very apparent that this is a very complex topic, and there's a lot of different ethical principles. So I use the 5 pillars of ethics that we discussed within our text as a framework to discuss this issue. I'm using this because within the literature that I found, they all went back to those ethical pillars, which makes sense. This is a presentation about ethics. But I will actually talk about 3 of the 5 principles because 2 of them are kind of couched within the other 3, and I don't want to. They play 2 of the principles play a very small part, so I don't want to dedicate a whole section to them. So the first thing we're going to discuss is autonomy, and we're going to discuss it within the context of the biopsychosocial model. So autonomy is the right for individuals to make their own decisions about their own lives. Within the context of the end-of-life counseling conversation, the principle of autonomy is highly elevated because this is a very serious, a very permanent decision. When somebody says that they want to end their life medically, that is a serious thing and triggers a lot of ethical considerations. So within the end-of-life literature, autonomy is often addressed within the framework of what we call the biopsychosocial model. So what is that model? It is simply a framework that was created to explain the interactions of the effect of complex illnesses and disturbances. So, think about it this way: if somebody gets a diagnosis for cancer, what does that influence? It doesn't influence their physical aspect. I think we all probably know somebody who has received that diagnosis, and there are, when they receive that diagnosis, it branches all the way through their lives, and it's a very, very complex thing. And so what this model is supposed to do is to really um, address that there are physical aspects, psychological, and social aspects. And there's actually another one that I will address later on that I believe should be added to this, but we'll talk about that a little bit later. In the context of the discussion, the model acts as an acknowledgement that each individual health element is tied to their mental health and their social components. So, former 2014 utilized this model to address the ethical considerations of individuals who seek out pass and euthanasia. Right, so we're not talking about suicide in these cases. We're talking about physician-assisted suicide and euthanasia. Specifically, because when you talk about the suicide, that brings in a whole more complex conversation, and this presentation would be probably double the length if we added that into it. Um, so the model represents a collaboration between mental health, medical, and social professionals when individual requests pass or euthanasia. And actually, it's not just for pass or euthanasia, but I want to underscore that it really is a serious thing, and all three of those sides should be working in collaboration in order to best help the client, or if you're talking about from a medical model, the patient. Um, so, in states where clients can request a legal termination of their own lives, they are required to obtain counseling to ensure that the choice is made of their own free will. So, this kind of underscores what this model is all about. Individual goes to the doctor, they receive a diagnosis, they receive a prognosis, and then that triggers a conversation with them and their families, and they make a decision, and that decision requires these three different components to work together. So in this case, where you have both euthanasia and physicians assisted suicide, individuals have to undergo counseling in order to assert that, hey, this person is on their own free will, they are of sound mind, and they are making this decision for themselves. This additional step is not meant to undermine the client autonomy, but is really done in order to ensure that clients are mentally competent and they can make a decision about themselves. If they're not mentally competent, then you cannot allow that autonomy, and that's an important ethical distinction there. Um, this autonomy, though, does not suppress the collaboration of the client counselor and the physician to make the decision making process that they need to do. But it allows the counselor and the physician to decide whether they are going to participate in the process, which brings us into a heavy ethical question. So, what is the implication of this last statement? We don't care about, I mean, we do care about, but specifically because this is a counseling program, what we're interested in is from the counselor's perspective. But this allows the counselor to determine if they're going to participate with the process of termination. But that, obviously we talked about this within our class, and it brings the question to ponder in what responsibility does a counselor have to the client in a scenario where they intend to end their lives through pass or euthanasia? We talked about what that means in terms of suicide within the class. We discussed it, and it was mentioned in our text. But we didn't talk about these two scenarios. So how do personal values come into play in this scenario? And so that's a big thing. I think that when we talked about the abortion topic, this is kind of related to where do your values sit versus the clients. And we discussed that multiple times. So that's something to think about. So the second is non-malfeasance. Non-malfeasance is the ethical imperative to do no harm to a client. Within the context of end-of-life counseling discussions, the biological portion of the biopsychosocial team has the heaviest burden because they have to determine if they're going to participate within this action. And I am sure that they have their own ethical guidelines that will help them through this process. But thinking about the therapy component, it is also focused on the client, but from a different perspective. This ethical dilemma posits the question, what do I need to provide the client to ensure that there is no further harm? So the assumption here is that the client has some harm because they're making this decision. They are likely in physical pain. And the question that we have to ask is, what can I do in order to avoid harming them more? In the case of end-of-life counseling context, consultation with colleagues is super important because there's a lot of different perspectives that have to be addressed. Physician consultation should also be considered, and we saw this within our text also for this very same scenario that brought me to this topic, where the text said you should consult with that person's physician if they allow them to, in order to get a better picture of what the prognosis is. But in this case, the prognosis matters quite a bit. So think about why that would matter to you. Furman 2014 discusses that it matters because if an individual has a very bleak prognosis, that is much different than somebody who has a high chance of surviving. And that kind of gets to another question that we'll talk about at the end, and a question that is a very difficult one to answer. Open communication with the client is very much necessary to ensure that their mental health is taken care of. So not only for the sake of ensuring that they're okay, but we want to ensure that all of the information is necessary, that we have. We have all of the information that we need in order to better serve them. So justice is the next that we will talk about. So justice is related to the principle of obeying the law, and it's really important when we talk about this because these practices of euthanasia and physician-assisted suicide are not legal in every state. So states have a lot of different laws concerning it. I looked up Oklahoma, and it does not allow either one of these things. However, if a person creates a valid advance directive, then they can request certain passive euthanasia measures within that. So this is one of the reasons why it's important to include legal consultation, and I think that may be part of this biopsychosocial model where you have to get legal consultation in times of very complex situations like this, because the advance directive has to be valid in order for you to be able to use or withhold interventions within some states. And looking at the bill that proposed this within Oklahoma, it is very clear that you should have a valid advance directive. And if you notice, whenever you go to the doctor, that's one of the things they ask you, hey, do you have an advance directive? And there was actually a federal law that pushed down the mandate for that question to be asked at hospitals. And it never even occurred to me until I read this, but when you go to the doctor and you have any kind of procedure, that's one of the things that they always ask. And it is for that reason that they want to ensure that individuals understand what the advance directive is and how it can benefit them. Worth 2002 asserts that the now famous Tarsoff versus the Regents of University of California case did not create a precedent that constrains mental health professions in a end-of-life situation. So what this study found is when we're talking about assisted suicide, euthanasia, you are not constrained by the precedent from the famous case that we read about in class. And looking at the ACA ethical standards, it's actually interesting because when this article was written in 2002, the Reth article, um, there was no mention of end of life decisions in either the APA or ACA ethical codes. But years later, they added them, and ACA addresses it. You can see it below, and they really leave it open to the practitioner of how they want to address these end of life contexts. And you can see the wording that I use here, and it really shows how complex of an issue is. In fact, if you look at the ACA ethics code of ethics and do a word search, end of life was only mentioned 3 times, and one of them is within the glossary. So my personal reaction to what I have researched, suicide and PASS and euthanasia are viewed completely different within the literature. As a matter of fact, within the literature, there were many times I received an article and I was like reading through it. I'm like, okay, this is interesting, but I realized I couldn't even use it because it's not addressing euthanasia or physician-assisted suicide. It's just talking about traditional suicide. They're treated completely different, and they seem to be cordoned off from each other. And I think one of the reasons why is because they're so complex. And I think that a lot of people don't want to go mixing those two. In fact, within Oklahoma, the language of Oklahoma, PASS and euthanasia are not considered suicide. And passive, what is called passive or euthanasia, is not considered suicide at all. Now, there is no allowance for PASS or euthanasia, but it is treated completely different from suicide, and I think that makes sense why. But it is still a very complex conversation. Very few states allow PASS and euthanasia. I remember when I was, I think I was like in my before I was a teenager, I remember the big conversations about euthanasia, and it was a pretty big deal. What was that doctor name? Oh, I can't remember. Dr. Death, he was talking about euthanasia, and I remember that conversation, and I thought that was so long ago, but there are still a handful of states, I believe I want to say 8 states and Washington, D.C. are allow some sort of euthanasia or physician-assisted suicide. Consultation is extremely important. I think we've mentioned that 1,000 times throughout this class, and this is definitely one of those situations where you want to consult with individuals who you trust, individuals who are your supervisors, and legal consultation may be appropriate also. So here's a quick scenario to kind of get you thinking. You have a client, Margaret. She's a neurosurgeon in a large city within the U.S. She is recently diagnosed with a terminal illness. She's completed 3 rounds of treatment. It is in severe pain. Her prognosis indicates that she will likely not get better from her illness. She tells you that she wants to talk to you about the possibility of PASS. She's talked to her physician already, but has not made a final decision. So with that scenario, think about the following questions. Have you ever pondered your views in relation to death? How do you think these views will influence your approach to these end-of-life scenarios within your practice? This is something I've thought about quite a bit. And just in general, it's a very interesting conversation. So the second one is, does the ethical considerations change if the client is in extreme chronic pain but not terminally ill? So in other words, if we go back to this scenario and we have Margaret, and she has an illness, but her prognosis is she's not terminally ill, but she's in extreme chronic pain. Does that change it for you? That's not an easy question. I don't think it's supposed to be an easy question, but it's something that I still don't quite know the answer to. So it's something to think about. Does your viewpoint change if the client was diagnosed with major depressive disorder previously? It's something to think about. Does that change the way that you view the scenario? Could she be in a depressive state right now? Something to think about. Does your viewpoint change if the prognosis for survival was at 50% or higher? Um, Something to think about. Does her education and background influence your viewpoint? I don't know. I don't know if it does or not for you. I don't think that it would for me. What I what comes to my mind is she's in severe chronic pain, and I think um, that is the thing that weighs on my thought process the most. But we may see her as more credible because of her education, or because we view her as having more to lose. Just some things to kind of consider. Um, and here are the references for this presentation. Um, I hope you enjoyed it. Thank you for listening.